Welcome back, everyone, to another episode of Talk with Toe. Taking a break for the holidays for a bit, but we're back here with Joy Evanston.
Hi.
How you doing?
Thanks.
And joining us again, Amy Hasson. And today we're just going to ask some questions about, medicine, hospital stuff, and nursing in general.
Mm-hmm.
So, how are you guys doing?
Doing good. How are you?
Doing pretty well. So,
Good
one
to
thing
be here in the Bay.
Yeah.
Reunited with Joy.
Yes.
We are here, staying dry and staying warm.
Mm-hmm.
It's been raining a lot. So you guys have both been working as nurses in different hospitals. So we're just gonna kind of see what are some similar things you guys may have experienced and maybe some different things that you guys may have experienced.
Mm-hmm.
But maybe asking you first, Joy, what has the experience as a nurse been like?
Well, it's been a little bit tougher than I thought it would be, a little bit longer transition period. So just as a general little about me, I work with a different patient population than Amy. I work with adult neurological patients at a big hospital here in San Francisco. But it's been difficult to get used to, but still really rewarding, and I'm excited for all opportunities with nursing in the future.
How long have you been doing that so far?
I've been a nurse for a little over a year.
Okay.
Yeah.
Nice. And are you still working nights, or you?
I'm not. Yeah.
Oh, wow.
I'm working days, which is a big gift. Yeah. It's pretty typical for a new nurse to start on nights, but I was able to switch back to days within a few months.
Nice. Actually, you're doing the same thing,
Yep,
right?
I'm still in the nightlife, but I switch in a few weeks to day
Nice.
shift.
So what are maybe some things that are different between night shift and day shift? Because since you guys have both worked, both shifts at this point, like what are some of the things that make night shift a little bit different than day shift?
I think that depending on the type of person you are, one might work better than the other. I think there's definitely pros and cons to each one. I don't know. What was your experience? Maybe I'm more optimistic.
The pace is different for sure. But I never liked it when I worked nights and people would just assume that patients sleep all the time, because there's still a lot of things you do at night. I would say day shift has more coordinating with things, so people go to procedures or scans, or just you get a lot more discharges during the day because people don't get discharged typically in the middle of the night. So it's learning how to kind of juggle those moving pieces. But at our hospital, you tend to have more resources during the day. So you have someone maybe that can come and do an EKG for you, but you don't have that at night. So there's different responsibilities and roles. And different pros and cons, I think, with working actually on the shift and then life outside of work too, because obviously that's affected by when you sleep and when you work.
So what does the sleep schedule usually look like?
I think there's many different methods that people use.
Okay.
For me, I like to work 3 nights in a row if I can, and then sleep during the day in between those shifts, and then switch back to sleeping at night on my days off, because I like sleeping at night. I don't know, I think there's some extreme people that just totally become nocturnal, but I think that's kind of rare. I don't know, have you encountered that?
No, I haven't met anyone. And when I worked nights, I kind of had my own things that I did to switch back and forth and try to always work 3 in a row. And I would do go to bed early, wake up early the day before night shift, and then take a nap. But everyone kind of does different things that work for them. Or some people I think just don't get that much sleep when they work nights, unfortunately.
Yeah, that's tough.
There's a lot of moms that go home and take care of their kids straight after working 12-hour night shift. They just don't get that much sleep.
That's crazy.
Some people just like can function like that.
Mm-hmm.
That's not me. That's why I'm moving to days.
Okay, so like when you guys are working night shifts, like what is I guess you typically have to do things for the patients still, right? So like how often does that happen? Like what happens if something goes wrong?
It might be different for you because you're on a transitional unit, which the differences between the types of units are like there's your typical medical surgical unit where depending if you're like with pediatrics, you have between 4 to 5 patients. It's kind of like the level of care the patients need.
Mm-hmm.
Transitional, you have how many? 3 patients?
I have 3 patients, yes, correct.
It's like another word for it is step down. So that's between like the typical medical floor and the ICU. So it's still critical care. But you have like 1 more or 2 more patients in some cases than you do in the intensive care unit where you usually have 1 or 2 patients because they just need like constant monitoring.
Yes.
Is that an okay description?
What was your question?
What was the question?
I guess what do
There
you?
was some point to that.
Yeah, like what happens?
How often are you interrupting them at night?
Yeah, how often are you interrupting them?
Depends on the type of unit.
I think it depends on the type of unit, it depends on what's ordered. Because I work on a neurological floor, we often have delirium precautions ordered for patients.
Okay, what do those precautions usually look like?
Just a lot of basic things to keep sleep cycles normal. So when it's nighttime, like closing the blinds, turning off the lights, clustering care as much as you can. We do bed baths for patients, so trying to do a bed bath like not at 2 in the morning, but after 5 in the morning. Yeah, things like that. But sometimes, you have to go in. You have to go in. Yeah, you have to kind of break those rules. But even when I work days, I try to like look at my meds ahead of time and see which meds I can give at the same time. Just because you have to be like efficient with your time and you can't keep going in and out of a room.
Trying to do procedures while you go in there to get their meds.
Yeah.
Doing vitals all at the same time.
Mm-hmm.
So you're in there for a longer period of time, but less frequently. So
What is like the procedure for giving out medication? Because obviously that's a huge part of what you guys do, but there's obviously like a process, and it might be different for different hospitals, I'm guessing, but... Like,
there's probably a lot of
most of them use the barcode now.
Yes.
Or do you not?
No, we do.
You do.
I was thinking of it in a different way in my head. Okay, sorry. Yes, we do everything pretty much electronically. I would say.
Meaning
what's
what?
the process? So you have to scan. Thank you, Mimi. You have to scan patient's wristband. You have to scan the medication before you give it.
Okay.
Yes. I would say as far as giving meds, they are scheduled at certain times throughout the day, and at our hospital, probably with you guys too.
You have a window.
You have a window of the hour before and the hour after before it becomes overdue.
Yeah. For us, it depends on the meds. Like the routine nighttime meds, there's like a 2-hour window, but for certain antibiotics, it's a 30-minute window.
Oh, okay. Yeah, that's different for us. So there's a lot of, I think, like a huge part of nursing is prioritizing. So sometimes you look and you have 2 antibiotics due at the same time, and you have 1 IV, so it's figuring out, do I do...
Which one first?
Which one do I do first? Is there potential, if they've gotten it before, that I could even do it at the same time with, a special type of IV tube setup? Or how long does it run? It's just like a lot of questions you have to ask yourself and get used to asking yourself. Yeah.
And you scan every medication before you give it?
Yes.
Part of the electronic
Yes.
process. Did you say that?
Yes.
Which is to prevent medication errors.
Yes, exactly.
Yeah. So where does the medication usually come from? Because obviously you guys have, you don't just have medication lying around, but like,
No.
Yeah.
Yeah, we just have a big pile of meds.
We
we just
stick our fingers through bare
that one
pills.
looks good. No.
It's just drugs lying around.
Yeah, exactly. We have a Pyxis, which is a medication loading machine,
Okay.
where we get some of our medication.
We'll cut that part out.
At my hospital,
I'll just put like a bleep sound.
we get a lot of meds delivered from our pharmacy as well, and they actually come on. I think this is different from where we went to school. I'm sorry, I'm like really used to name dropping, I guess.
Yeah.
It's okay to say where we went to school.
Yeah. Okay. You see, you're fine. I just feel like it was different. I already forgot. But we get a ring and have like meds attached on the ring with the patient's name and the list
That's what you have now?
when they come from pharmacy.
Okay,
Yeah.
so I was going to say, I don't remember that from school.
No, I'm saying it's different. And then
So that ring is like a ring of like just labels, or is it like?
it's kind of like
ring of
if you think of a
bottles.
key, a key ring, and you have like keys hanging on it. It's like a little plastic bag. It's a lot of plastic. So,
So like the meds are in the plastic on a
Yes.
key ring.
Each med is in a separate thing. They never put two meds
Right.
in one.
Wow.
Yeah, or we have to sometimes pick up medications and controlled substances are never on the rings too. We always have to pull those and count those from the medication machine Pyxis. Yeah.
Do you guys do the same thing at your hospital, or?
No, we don't have those rings, and the pharmacy will just send it in like one bag for the patient, and all of their meds are in the same bag for most of them. And then there's like, so for us, like all of their PRN, which are like as needed medications, are in our Pyxis, and then everything else that's specific to that patient gets delivered from pharmacy. And then we have a cassette with all of the patient rooms on it, and the pharmacy puts the patient meds in there, so they each have their own little cubby, and it locks. So then when you want to get that patient's meds out, there's like a code you type in. It unlocks the whole machine so you can get it out for any of your patients. And then the only time you use the Pyxis is like the as needed medication. So if they have medication for nausea as needed, that's like when you would get it from there instead of in their own little cubby.
Do you have people who might not know what a Pyxis is? Like, how would you describe it? Because it's kind of like a device.
And I say Pyxis, like there's different terms. Ours is actually called an AccuDose, but different brand, same type of thing.
Yeah.
I don't know, you can describe it.
It's like a bunch of cubbies or drawers. I don't know why I really like the word cubbies when you said it. It's like a bunch of drawers that open up automatically when you request a med from it. And it's often just like not one med for each drawer. It's like a big drawer with a lot of
like 15
compartments.
to 20 minutes.
Yeah, and so it'll say like remove like one stool softener in pocket 10 or something like that, and then you pull it from there.
So the drawer will open, but only the pocket that med is in will open. So you can't get meds that like you're not supposed to be accessing.
So you can like see all the meds in the drawer, but the only one that you can
only
get
get
is
the
the
one that
you
opens.
Yes.
Got it. I mean, that makes sense. You don't want to accidentally grab the wrong meds either, so.
Yeah.
We also have a fridge with certain medications. That same thing opens up.
Yeah, some medications need to be refrigerated.
A lot of vaccines.
We have a refrigerator
Yeah.
for breast milk because we have babies and some of them are being breastfed, so the moms can store their breast milk. But it's still labeled like a patient med, and you can actually scan their breast milk label to make sure it's going to the right baby.
Oh.
So that's something that's maybe a little bit different about pediatrics.
Okay.
Yes, we do. We do sometimes get patients that breastfeed, very rarely, but we don't have a real special system for that. We just keep it in a fridge somewhere. But yeah, that is different.
So what happens if patients don't want to take the meds? Because that obviously is something that usually the nurses are the ones dealing with that. So.
And that varies between adults and pediatrics, which we were talking about. So what happens for you, Joy, when your patients don't want to take meds? What do you do first?
I think anytime a patient refuses something, I want to make sure they're adequately educated on why it's ordered and why their doctor, why medical staff believes it's needed. So they have a right to know. But with adults, they have a right to refuse. So I don't do much always. Yeah, I realized though that, and it is also difficult because my patient population is confused easily, so that's kind of a whole nother thing to navigate and consider, I guess, ethically. But with adults, they have the right to refuse. We do not force them to take meds. We don't open up their mouths. Yeah, sometimes maybe I'll take a couple extra steps to, if it needs to be crushed in applesauce, then I'll put it in there for them. And maybe they change their mind when I bring it up to their mouth or whatever. But yeah, ultimately, adults have the right to refuse. So, yeah.
And that's why you try to give the most important medications first, right?
Yes, in
case they stop wanting to take them halfway through.
Yes. Most of the time, yeah. Sometimes my patients take all their meds, so I don't have to worry about that as much. But yes, I try to warn my colleagues that this person likes to spit out meds, so give them the important ones first. Yeah. What do you do, Amy?
Well, working with kids is different because their parents are the ones that consent for them. So if parents say the kid gets the med, then the kid gets the med, one way or the other. So first, you just try to see if the kid will take it. And there's a lot of like really sweet kids that they just want to get better. That's if they're old enough, like I'd say like above 5. If they can understand that they kind of need it to not feel sick, then they're more willing to take it. If they don't want to take it, we try to like entice them with like saying, oh, maybe you can play some video games after, or maybe I can find you a cool sticker, like kind of bribe them. If that doesn't work, then we kind of just like have to hold them down. So usually like sometimes meds can be, giving meds can require multiple people, because we usually try not to have the parents help hold the kids down too often, because that can be pretty traumatizing for them to feel like they have to keep holding their child down for things. So we usually bring in another staff member, and if they're young enough, we'll like wrap them up in a tight blanket, like their arms and legs so they can't really move.
Like a straitjacket.
Pretty much. Like a straitjacket for kids.
Oh gosh.
I sound terrible, but it's because they need it, and then like one person will hold them down, the other person will like kind of force their mouth open. And usually kids, if they're younger than teenagers, all of their medications are like liquid, as much as they can be. Or if it's a pill, you always crush it and put it in something, because kids don't really know how to swallow pills. So that's also a difference. So you usually are squirting a syringe of liquid into their mouth and holding it close so that they swallow it.
Different we call different forms of medications routes of administration. And so, that just made me think. Sometimes, like I had a patient who was it's not always about refusing, especially on our floor. It's issues with swallowing sometimes, or sometimes they're too sleepy because things with your brain can make you really lethargic. So, like a seizure medication is really important, and so there can be forms of it in IV. So that's one thing. IV, or we put feeding tubes in people that we get them meds. So those are other options besides just saying the patient.
Like they definitely try to do least invasive first, or most effective. Like for antibiotics, usually they don't start with ones that you take by mouth if it's a serious enough infection, because the IV form is usually more effective. I don't know if you've experienced that, Joy. But if the medication's just as effective either way, they'll try to do least invasive, like by mouth first. But like Joy was saying, if a person's not able to do that,
Yeah.
you can give things other ways. Like some antibiotics can be given as an injection, so pretty much like the same way you get your flu shot. We'll do that for babies sometimes if we can't get an IV on them. Sometimes it's really hard to get IVs on babies.
Yeah.
Yeah.
How many IVs do you guys do normally do in a day? If you were to guess, I mean.
I don't do them that
Yeah.
frequently. I could definitely use the practice.
If they come from the emergency department, usually they're started there already. So really, it's only if their IV stops working, or if for some reason they need like multiple IVs. So
Yeah, which could be because of multiple medications. But yeah.
maybe like once every few shifts, there's like an opportunity.
Yeah. It just depends.
In the emergency department, they do it all the time.
Yeah, that makes sense.
So I guess it depends where you work also.
Well, what are some things that maybe frustrate you about hospitals?
Oh my goodness, do we have another hour?
We got plenty of
Sorry,
time.
that's
Yeah. What frustrates you, Joy?
Because we always want to improve healthcare, obviously, but
Yeah.
yeah.
What frustrates me? How do I say this in like helpful?
What could be improved?
Yeah, what could be improved,
What
I
could be
guess.
improved? Do you want to go first, or do you want me to go first?
Do you have something?
I have things, I guess, but yeah, I don't know. I think like equipment not working is always very frustrating for me personally, because our jobs are already really busy, and so when something doesn't work and you have to spend the time to like find the right equipment, or spend time like notifying someone to fix the equipment, it just takes extra time that you normally don't have. What are other things that are frustrating? I don't know. I think I'm learning to like accept that a hospital is like a place where I can do a job that I love and help people, and it can be rewarding, but also know that it's not going to be perfect, and to learn to let go some of the things that were like super frustrating when I started. Whether that's like communication, like not hearing back from another staff member, or
Yeah, that's something different on your unit because you have a lot more surgeons that you work with. So they might be in surgery. So if you're trying to call them,
can be frustrating.
which is not necessarily anyone's fault, it's just something that happens on your unit more frequently.
Yes. Yeah, I think sometimes it's frustrating when you enter a job where you want to help people and patients aren't in a place to receive maybe all the help you want to give. And just learning to be compassionate nonetheless. Yeah.
I was going to say charting.
Charting can be
There's
frustrating, yeah.
a lot to chart.
What does charting like look like for? Because I think a lot of people might hear nurses talk about charting, but they've obviously never experienced it or done it themselves. Like I haven't. So like, what is normally like what does charting usually require of you guys?
Well, I think I talked about like the assessments before. There's like pre-selected options to help speed up the process for like how your patient might be doing for different systems of their body, but like also like everything you do, you pretty much have to chart, because if it's not charted, it's not done, is like the famous saying. I don't know, I'm sure you've heard that before.
Yeah. Or we say like chart things that maybe kind of leave you less liable as a nurse. Like if you did your job to advocate and communicate on behalf of your patient, like write a note. So that may be more what people think of as that we do like notes, but a lot of it is, I think Amy talked about in another podcast. A lot of it's like pre-selected things or choices that you select.
It's like small things too, like if you change like, so the pulse ox is like it measures like the oxygenation of their blood. There's like a sticker that will hold it on.
Mm-hmm.
If you move that to another finger, like you need to chart that because that's showing you're trying to prevent skin breakdown. So I think a lot of the charting is like trying to show that you were giving adequate care so that like you're trying to prevent like if a lawsuit ever comes up, like it's seeming like you weren't giving adequate care because like if you didn't chart it, they don't know if you ever did it. So like sadly, there's a lot of pressure to like make sure you have everything like charted, which I think when you're new, so maybe like I struggle with this more still since I'm newer than you, but like I want to have time like to spend with my patients also, but then I'm like trying to balance like time management of like always in the back of my mind of like I have to be charting like all of this too. I don't know if you feel that.
Yes, I do get frustrated with feeling like I want to be present, be with my patients rather than putting something in a computer, but then realizing that you have to stay on top of it or you'll forget things pretty easily because you have a lot of things going on in your mind. But it's definitely like charting what you do as well, from simple things like how much did they eat or drink or urinate or whatever, to like medication is technically part of your charting as well, to assessments. We chart care plans and education. So there's a lot of components to it.
The education component is like obviously very important, right?
It is. I think it's sometimes one of the things that
like
we feel like
if there's something that you can kind of spend less time on.
Yeah. Also, it's hard to like succinctly describe what you've educated a patient on in one little note or.
So what does yours look like for education?
Ours have different topics that we can choose, and then you describe.
Is it like a check mark?
It's check marks. Though we were really focusing on stroke education, we had a big like survey at the hospital, and so we were supposed to do notes more descriptive, kind of a narrative, saying like what we talked about regarding stroke, and then just like check marks of like who you educated, what method did you use, an interpreter, did you explain it, did you have them teach it back to you, things like that.
Because there's different methods of explaining things to patients. Like if you just talk at them, they might not understand it. So you said teach back.
Yes.
So what is that?
What is teach back?
Teach back is like having someone explain it back to you, or sometimes I do return demonstrations. So like I have patients that are just starting on insulin, so we have like supplies that can kind of mimic giving insulin, or like I'll actually have them give it to themselves while they're in hospital, or different shots to prevent blood clots. I have them or a family member teach it back to me either verbally if the opportunity is not there for them to do it in person, or do it in person in front of me, so I can guide them and give them feedback, things like that. So that's teach back / demonstration, I guess. It's just what it sounds like.
I mean, that's super important because, obviously you're hoping that they eventually leave the hospital, but if they need recurring care, like you're not going to be there. So you want to make sure that
they know
how to properly give care.
So if you see it, like if you have them demonstrate, then you actually know that they know how to do it.
And I think we're one of the kind of stops or safety checks for a patient being discharged, because we are interacting with them a lot, so we kind of are the eyes seeing if maybe they can't really go home safely at that point until they're educated properly. Because sometimes patients don't go home. They might be medically clear, but they might still not go home if they're not ready. Yes.
Like with kids, sometimes family can't be around, and if the kid is going home with a medical need that the family needs to take care of, like the kid might be medically stable enough to go home, but sometimes we had to keep them a few days longer because the family wasn't able to come to learn how to take care of the kid, which is sometimes like understandable. Like sometimes the family has other kids at home and both parents are working, and sometimes parents like just aren't as interested in the care, which is like pretty rare still, I think, in pediatrics, luckily, but yeah, which is probably something you still deal with in adults because a lot of these patients are being taken care of by family members when they're older.
Yeah, I would say there's been a couple times where I felt like I've had to speak up and say, hey, this person is not safe to go home. Or maybe their situation isn't inappropriate, or sometimes like one time I had to speak up because the way a patient was getting transported to a facility was not safe for him. So those are some things that can be frustrating, and sometimes they create more work. But I think, it's part of your job to advocate and speak out.
Make sure they're safe.
Yeah.
And the doctors are the ones who ultimately make the call of whether or not they get sent home, or how does that process work?
I would say, but there's, like for us, PT.
They're not, physical therapy.
Physical therapy evaluations are really important because it determines how they move and how, like, if they need more therapy or things. So they play a big part
like
of
a collaboration.
that.
I would say like the doctors are like getting input from nursing and physical therapists to see if it seems like the patient's ready, and then hopefully that's the case, and then they'll make the determination, and like they'll be the ones to officially put in the discharge order.
Yes.
But I think there's a lot of collaboration.
Yeah, there is.
Yeah.
So you say you guys get a lot of stroke patients, right? I think there's a senior design team, at least at UC Irvine, that they were talking about trying to find a way to determine the difference between, different types of stroke. I don't know if you're aware of like the.
No.
Okay, I think there's like different there's like ischemic strokes and hemorrhagic strokes, and like I don't know enough about like what the treatments are, but apparently they're very different.
Yes.
And if you do it incorrectly, you could kill a patient or something. So like, I don't know, maybe you would know what the difference in the treatments are and like what that looks like.
Yeah, so disclaimer, I am not an expert, but I'll share my basic knowledge. So ischemic is typically caused by a clot, is how I explain it to my patients. So ischemia is like tissue that dies, basically in the body. So you can have ischemia not just in the brain, you can have it in the heart, which is what basically a heart attack is. So ischemic stroke is basically a clot typically is blocking blood flow to the brain. Or a hemorrhagic stroke, so it sounds like hemorrhage, is bleeding, which is often caused by trauma, like a fall. So when someone hits their head, especially at the hospital, or if we know beforehand, then that's a big thing that we're worried about. Sometimes it can be caused by an aneurysm, which is kind of like a part of a vessel, like a vein or artery that's weakened. It's kind of like a pocket normally that like pops out. Yeah, and it can
like
burst.
a pouch.
Yeah, a pouch. Yeah, that's what I was looking for. So those are some basic, stroke 101s. But the treatments are very different because you can either try to remove or dissolve a clot, or a lot of times with hemorrhagic strokes, you're just kind of waiting and monitoring. But if you treat one of the treatments, I'll try not to get into like too many technical terms, but one of the treatments to dissolve a clot is a medication called TPA. And if you give that to someone with a hemorrhagic stroke, you could cause more bleeding, so it's very dangerous. And there's also complications where people sometimes have both. Or you have a lot of things that you're trying to balance, especially with older patients when they're on blood thinners for heart condition, and then they get a hemorrhagic stroke from a fall, and so you stop them off the blood thinner so they stop bleeding, and then they get an ischemic stroke because they're not on medications to prevent that, if that makes sense.
Yeah.
So it's a balancing act. Trying to figure out what's best, and there's also time frames for treatments. So we always say time is brain with neuro, because if you notice stroke symptoms, you have to treat things right away, or it's past the safe time to do so.
What is normally that time frame? Like how long?
I was just supposed to know this week, so I guess that's good. So a thrombectomy can be within 24 hours of, we say, a last seen normal. So when a patient was not seeing symptoms.
And a thrombectomy
is like a clot.
Thrombus.
Yeah, it has like a clot removal. And then TPA, which is the medication that dissolves clots, is within 4.5 hours of last seen normal time.
Wow. You really don't have that much time, because
No.
even just bringing a patient to the hospital sometimes can take like maybe an hour, 2 hours.
Yeah. Or sometimes
And if they don't call right away.
just think, maybe it happens at nighttime, and well, let me just see how I feel when I wake up in the morning. Like that's already too late. Yeah. So it's important.
Neurotrauma is definitely a hard one, because the brain is like just hard to treat in general, I feel like.
Yeah, there's not a ton of things you can do with the brain, because we still don't, I think, know a lot about it, and there's just not a ton of things you can do safely as well. So nursing and neurology is a lot of monitoring and assessing, and just like looking for changes, and that can be very subjective. I think sometimes that's what's frustrating. Pointing out the frustrating things may answer your question.
Yeah.
But I promise nursing's good, so don't think I'm a negative person, people. But yeah, because it's like, is this person just sleepy, or are they having more bleeding right now in their brain, and so you have to be confident in your assessments, and also ask for help from others. And I would say it's better to overpage a physician than for something really bad to happen. And
better safe than sorry.
Yeah, exactly.
So what are some of the tools you guys use to monitor patients?
Assessing is just basic things patients do. We do have specific drains for neurological patients. So we have drains that go into their brain and collect cerebral spinal fluid, which is a fluid that bathes the brain and cushions the brain. So they either go in there's one that goes in a brain, and then there's another one, a lumbar drain, that goes into their spine. And with both of those drains, we measure CSF output from the drains. We measure pressures in the brain. Those are the big things that we measure. And you have to be very careful with those, because you could accidentally drain too much, or if you're not draining enough, then pressure can increase and can cause someone's brain to move. We say herniate, which is could kill someone. Yeah. So those are, some basic things, I guess, but monitoring.
Yeah, that's crazy, because also for for trauma patients, right? The typical, I guess, treatment, if you were to say, to prevent the like swelling of the brain is basically like a skull removal.
Yeah,
right?
removing a piece of the bone. Yeah.
Yeah.
Mm-hmm. Sometimes we say like it's like a box in there, and you have like your skull is the outside of the box, and you have your brain and the CSF, the cerebral spinal fluid and blood, and if anything else gets in there more, then it's too much pressure. Yeah. Yeah, so we get a fair amount of patients that, we don't have trauma patients on our floor, but there's still things that happen that, require, a bone flap to be removed. So we have patients without pieces of their skull, and they have to wear helmets.
Why is that important? I mean, I know, and I feel like that's self-explanatory.
The helmet?
Yeah.
What are the helmets like, I guess, too?
Like, they need to wear it all the time, right?
No. Our patients just wear them when they're out of bed. But some of them, don't get out of bed, so when we turn them, we typically don't turn them on the side where there's like open, exposed. And don't worry, their skin, I'm not just like seeing burning open. You probably knew that, but
it's pretty much just like brain and skin.
Yeah.
Which is why if they're walking, you need the helmet, because if they fall and hit their head, they would be hitting their brain directly.
Yeah, and it could cause, obviously, more damage. What do the helmets look like? Did someone ask you that?
Yeah.
Have you ever seen babies with those helmets to reshape their like skulls? Okay. Well, that's a kind of a common thing now, is that babies, when they're on their backs too much, which is like a whole thing with sudden infant death syndrome and sleep safety, but they're getting like flatter skulls. So they wear these helmets. So if you've seen those, it looks like that, but for adults, I don't know what it's made out of, to be honest, but it's not, I don't know, it's kind of like a bike helmet, but probably made out of different materials. Yeah.
That's crazy, yeah, because I know there's like a lot of research in like how to protect the brain after those surgeries and also prevent infections, because like that's obviously a huge problem too, or like the risk for infections and brain surgery is like pretty high. Even if you like maintain sterile fields and stuff like that, it's still like a huge risk, but yeah, it's crazy. Well, you love your job though?
I love parts of it, and I'm learning. I think it's just going to be time to get used to it. Yeah, there are hard parts.
Yeah.
But I'm proud to be a nurse, yeah.
Some days it feels like you're being really helpful. I was explaining this the other day, and some days it's like, well, for me, I will spend like 3 hours trying to convince a 2-year-old to pee. Because we really need to make sure like that there's nothing wrong with her kidneys.
Yeah.
Like, is she just being stubborn and not wanting to pee? I'm like, yeah, I spent 3 hours like just basically bribing a 3-year-old trying to get her to pee. And some days you're doing more things than that. So
yeah,
I'm sure it's different with adults, but I'm sure there's comparisons in those feelings.
We still bribe adults to pee, so just saying. Yeah, I don't know, I think I'm still on a transition part, but I do love a lot of things about nursing, but it's not perfect,
What about the hard things?
What's that?
I don't know if we talk about that a lot. Like, it's hard sometimes. Like, well, for me, my patients are kids, and usually they're resilient, so they get better a lot. But, like, your patients, you don't know if they're going to get better after a stroke.
Yeah.
Do you get used to that, or?
A bit. I think I get really excited when I do see changes, when someone's less confused or walking or moving around. Like, I get super excited because we don't always see that in neuro. I think it's hard when like traumatic things happen and you've seen a patient somewhat healthy and normal, and then you see them get sick very, very quickly. That's hard. And it's hard to not doubt yourself, but also being, willing to know, what could maybe have gone better. And I think, maybe that's my personality too. It's hard for me to not always let go of things and be confident in the choices that I make. hard job. But it's
Yeah.
a good job. I do love nursing. Yeah.
Yeah, I mean, the healthcare system would definitely not work without nurses. So
Yes.
thank you guys for.
It wouldn't work without the whole team, though.
Yeah.
Yeah.
Yeah, everyone's really important, especially like for us respiratory therapists,
Mm-hmm.
because we have like pediatrics, like, but we're mainly a respiratory unit, which is like lungs. So they're very helpful.
Mm-hmm.
Yeah, we have a lot of cystic fibrosis patients, and they need their treatments at least 3 times a day. So those vests, like you may have seen the videos that kind of vibrate and like help them to cough out all mucus. The respiratory therapists do that part.
Yeah. Yeah, I would say, like, with neuro issues, because every body system is involved, that it really is, yeah, multidisciplinary, that, like, our rehab team is so important, which is, like, our physical therapists, our speech therapists, our occupational therapists, our respiratory therapists are really important. We get a decent amount of patients that have tracheostomies because they can't protect their airway. So, yeah, all of those people are really important, and they each have expertise in their unique fields. And to the nurse, they're, yeah, extremely important. And obviously the physician is
Really important.
Yes, really important, yeah. So, yeah.
Well, maybe what is something you would tell people who might be interested in getting into nursing? What should they maybe think about before? Like, what are maybe some things you wish you may have been more prepared for, or just like cool things you might want to tell someone who's like considering going into nursing?
We're smiling at each other right now. If you can't see us on the podcast, thinking intently.
Making sure we have some wise words.
Yeah, I want to play like the Jeopardy theme song right now.
Joy loves Jeopardy. She calls it Geo Party.
You can cut that out, Chris.
Oh no, I'm leaving it in.
The world needs to know about Geo Party.
What do I want people to know? I feel like a lot of nurses, and maybe you're getting this vibe from me if I don't seem grateful for my job, which I'm sorry, but there's like a love-hate relationship with the nursing because, yeah, it's a really difficult job. You're kind of at the hub of everything, and you're experiencing so many things with your patient and with their family members. So, yeah, it is really challenging at times, and managing that expectation. But it also is extremely rewarding, and you get to do insane, crazy things that maybe your typical friend or person in the office doesn't get to do. I would say, especially in the hospital, it's never boring. You're always on your feet, always something to do. Yeah, and that you also just can connect with other humans in a really, really special way, because you're with people in the most vulnerable times of their lives, and family members too. Yeah. So yeah, it's a great hard job. Yeah, but it's a good one. That's my best summary, I guess.
I think that's pretty great. I agree. Like, when it's hard, it's hard. Like, with kids, we'll get the kids that have, maybe child abuse. Yeah. Babies with fractured skulls, things like that, that you didn't know because they came in for something different that you find later. Things like that are hard. I mean, luckily we don't deal with that many patient deaths on my unit, but in nursing school, you probably will if you go through critical care. So yeah, there's things that are hard. So the important thing for that is just, I think, talking about it with fellow nurses is the most helpful thing for me. And in nursing school, talking about it with my nursing classmates that I was closest to, because you're dealing with all of those things while still being in school, or like trying to manage work depending on what stage you're in. Yeah, but it's also like really rewarding, like Joy said, like when you get to see, like for me, kids get better and go home, and even if that means they're going home to a foster family now, like those things are like really cool. And there's also like just such a variety in nursing. Like if there's a certain unit you start on and like you don't really love it, you can always try something new. At least right now, like I think there's room for that in nursing, especially like while you're younger. I think a lot of people kind of try out a few different units in the beginning of their career, from what I hear. So like it's not impossible to jump to a different kind of unit. So yeah, there's like such variety,
Nice.
which is really cool.
Oh, that would be a good place to leave it off. So, yeah, thank you guys for taking the time and just talking about the great jobs you guys are doing. I think if you guys are listening on the podcast, be sure to thank your nurses, because, you know, we're all going to be probably in the hospital at some point, to be quite honest. And, yeah, I think most of us have probably had experiences already, and just saying a word of appreciation goes a long way. So, yeah, thank you guys for taking the time.
Yeah. Thank you, Joy. Nurse Joy. Thank you, my nurse. Thank you.
Thanks for listening. Hope we didn't bore you with all of our nursing talk.
We tend to do that.
Alright, stay healthy, guys. Be sure to like and subscribe to Talk the Toe on Spotify, and also give us that 5-star rating on iTunes. Also, be sure to go to YouTube and subscribe to Talk the Toe. Talk the Toe is written and produced by Chris Toe.